This discussion on behalf of the Aspergillosis Trust. So we're a group of patients who all are aspergillosis patients. We maintain a website, we do social media and outreach and so forth. We also graciously accept your donations. But that being said, all of our content is free of charge and you can look us up. We have a website, we're on Facebook and on Twitter. Myself, my name is Bart. I am an ABPA patient under the excellent care of the Manchester Clinic. So in other words, if I cough every now and then, I apologize, but it's part of the package. My guest today is Dr. Anand Shah. Do you want to introduce yourself?
Yeah, thank you, Bart, for inviting me. So my name is Dr. Anand Shah. I'm a consultant respiratory physician at the Royal Brompton Hospital, which is part of Guy's and Thomas's Trust. I specialize in respiratory fungal disease, so we manage a lot of patients with allergic bronchopulmonary aspergillosis and also chronic pulmonary aspergillosis. And academically, I work at Imperial College as well, doing a lot of research within fungal lung disease.
Excellent. And so you published in October an article that I thought you were co-publisher of a really great article called, let me get that right, Review of Current and Future Therapeutics in ABPA. And actually, being a patient myself, this was the first time I kind of felt I understood what was going on. So what I would want to do today is, that article is a bit heavy going, to be honest. If you're not a scientist, so okay, whatever.
Sure.
So let's just go to basics. And firstly, what is ABPA? How's it diagnosed? How does it relate to the other aspergillosis variants? How would you define that?
So allergic bronchopulmonary aspergillosis, which is termed ABPA, it sits on a spectrum, and this is kind of where Aspergillus as a pathogen is interesting. So Aspergillus is a mold that, as I'm sure you know, is all around us. It's all around us in the air when we breathe, and every day we kind of breathe in spores. And if in a normal setting, if you have a good immune system with no problems with your lungs, you clear them without causing any damage. Now, with Aspergillus, unfortunately, there's a huge range of problems that it can cause, which is probably relatively unique amongst all of the pathogens that you may encounter. So it doesn't just cause infection. You can either range from what we just term allergy, so it doesn't really cause any particular problems in the lung, but it causes an allergy to the actual mold itself, and that can be as a sort of a contributing factor to asthma, for example. On the other side of the spectrum, if you have a completely abnormal immune system because of chemotherapy, or you're very sick in intensive care, or a number of other drugs, for example, it can actually cause invasive disease and cause an acute infection, which unfortunately has a really high mortality, which we've seen in the context of COVID, for example. Now, ABPA sits in that spectrum where it's kind of more towards the allergy side of the coin, where you have an overactive immune response down an allergy pathway. And as a consequence of that, you start to develop destructive changes within the lungs. And the most common feature of that is the development of what we call bronchiectasis. Now, bronchiectasis is really just an X-ray terminology or an X-ray description, where what it's describing is that the airways become dilated, thickened, and they secrete more mucus. And characteristically with ABPA, you get much more dense mucus that you see on the imaging because it contains fungi within that. So that, in a nutshell, is ABPA, where what it's meaning is that you have an allergic response to the Aspergillus, which is driving lung disease, which is characterized by bronchiectasis.
Yeah, and I understand also that it's much more likely to occur with people who have asthma or cystic fibrosis, right?
Yeah, so there's certain conditions that predispose you to ABPA, most commonly asthma, but equally cystic fibrosis. But there are a few patients where they don't fit neatly into that bucket either, so they don't really have a clear diagnosis of asthma or CF, and we sometimes still see ABPA in those patients as well.
And for my understanding is also that ABPA is not normally curable, but also it's not like an immediate lethal disease. Like it takes the time.
So it's what we call a chronic disease, and it develops, usually by the time we pick it up in a clinic, I suspect it's often been there for many, many years, and it's slowly been causing problems which then manifest in terms of the need to go see a doctor, and then eventually get diagnosed and get picked up. And I think that's one of the problems, is that it can masquerade as lots of different things, and often because of that, it sometimes does get picked up late. It isn't curative in the sense that at the moment we don't have something that can turn off it completely. There's lots of therapies to manage the disease. Allergy is a funny one in the sense that the body in itself can sometimes what we call sort of burn out the allergy. So when people say they were allergic as a child and they grew out of it, that's sort of one of the ways of saying, actually the body itself can sometimes actually, have less of an allergy over time. And we do see that with ABPA, where we sort of term it almost sort of burnt out ABPA, where actually the allergies over time tends to sort of die down, but obviously it still leaves you with any of the destruction that's happened or the bronchiectasis that's, as a result of that process over years.
Yeah, that's really interesting. I didn't know that actually. But so if we're talking about management, like nowadays, my understanding is that the most likely management would be antifungal medication.
So historically, the most common treatment has been steroids, which are actually a very, very effective treatment for ABPA. Even now, when we talk about treatments in ABPA, I think the first thing to highlight is that the relative lack of evidence-based treatments that we have. So there's been some really great work out of colleagues in India who have really kind of probably led the way in terms of performing randomized controlled trials in ABPA. But outside of that, which I can probably count on one hand, there isn't really a lot of evidence-based treatment, and most of it's been based on experience over the years. But it has been predominantly related to corticosteroids, so prednisolone, which is a tablet which you take.
Yeah.
The problem with using them, although they're very good, is the side effects that go with that over time. So because of that, we've looked for other treatments that have tried to what we call a steroid sparing effect. So it means that you don't have to rely on the dose of steroids over time. And antifungal treatments are probably the mainstay of that.
Yeah.
The recent trials have looked at how you could potentially use antifungal therapy instead of steroid therapy, and those have been very interesting to see kind of the comparison.
And so I actually take antifungals, Sporanox, and I do very well. But my understanding is that they're not all the same. There's a group of antifungals, right? Actually, there's a number of categories.
Yeah, so I mean, the sort of tale of woe continues in terms of antifungal therapy, in the sense that we don't unfortunately have as many as you would expect in terms of antibacterial therapy, for example. So we're limited really to probably about 3 classes of antifungal drugs, of which only one of them is available in oral formulation. So it's suitable for long-term administration in an outpatient based setting, and those are the oral azole drugs, so AZOLE. And there's a number of different drugs within that class. So the most commonly used is itraconazole, primarily because it's been around for a long time. It's relatively well tolerated. It's relatively cheaper as well. And then there's some of the newer azole class drugs, such as voriconazole and poraconazole, and there's a newer one as well called isavuconazole. Now, as the newer azoles or the newer drugs are formed, there's less evidence base to use within an ABPA setting at the moment. So often they're not always licensed for use in ABPA. And equally, they each have their own toxicities and issues. Some of the newer ones, though, are promising in the sense that the absorptions of the drug are definitely better. And what we don't know is whether one antifungal is necessarily better than another antifungal. So we've got some interesting data in cystic fibrosis that shows that may be the case, but there really hasn't been any studies looking at that within ABPA.
Yeah, so that is actually an important part of your article, is that you looked at the scientific evidence in terms of A/B testing, and noted that in many instances it seems to be inadequate. That's correct, or
when you say inadequate in terms of the antifungal therapy is inadequate, or you mean the evidence base is inadequate?
Generally, in terms of therapeutics.
Yeah, I mean, I think that the major message, I think, probably from the article, we went through kind of quite systematically in terms of the different options that are there. The thing that strikes out really is that there's a general lack of studies that have been performed in ABPA, and that's partly because it's a rarer disease. Well, up till now, it's been thought to be a relatively rare disease. I think I would argue that's not always the case, but equally, the evidence base just hasn't been there. So we're often reliant on licensing for severe asthma often, and that's certainly for the newer drugs that are coming through the market. And that doesn't always necessarily fit the patient groups with ABPA, because often they were actually excluded from the original studies. So the licensing criteria then reflect that. So it is a problem which needs addressing moving forward for sure.
Okay, and so I think one of these would be monoclonal antibodies, right? Like Xolair. That's,
Yeah.
I believe, research for asthma, but not so much for ABPA.
Yeah, so it goes back to kind of why we think the ABPA is developing, or the pathways which we think are actually important in driving ABPA. So we know it's an allergic disease. So the key components of the immune system that are important for allergy are something called immunoglobulin E, which is made by our immune cells and is a sort of driver of allergy. And equally, the blood cell, which is really important for allergy, is the eosinophil, which evolutionary was sort of there to protect us against parasites, but equally can drive allergic disease as well. And there's probably the biggest groups of monoclonal antibodies, which effectively are synthetically made molecules. They're not drugs as such, but they're pharmaceutically derived molecules that target very precisely the points in with the immune system which is driving allergy. So the first one that was available in severe asthma was called Xolair or omalizumab, and that targets the IgE part of the spectrum. Now, and that's been incredibly successful in asthma, and you know, it's been used sporadically in ABPA, but really the trial evidence doesn't exist, and the licensing criteria often mean that patients with ABPA who have very high markers of IgE are excluded from using that. So there isn't really a lot of evidence. We use it on occasion if we can try and get people who meet the criteria within a severe asthma licensing spectrum, but you need to fit very, very careful criteria. The anti-eosinophil drugs, again, are even newer, and they potentially hold a bit of promise as well. But again, those studies really haven't been done. And so, again, the future, I think, is quite bright, but it does need some really kind of really good efforts to develop the trials within an ABPA setting. And that is happening. So there is now a global trial of another monoclonal antibody called dupilumab, which targets another aspect of the immune pathway. And that's probably one of the first drugs that's been done in a global sense to look at these monoclonal antibodies for ABPA.
So my understanding is that Xolair is very expensive, right?
They are very. All of these drugs are pretty expensive, but I think if you contrast that against healthcare utilization, you know, the antifungal use, and the number of times you need to go into hospital, often it can be, you know, equivalently cost saving. We've seen that with asthma. So it's, I guess, making the case that actually, you know, these drugs potentially can be helpful. Now, you clearly probably wouldn't want them at an early stage if you aren't requiring a lot of treatment, you're not that particularly unwell, you're not need to go in hospital very much. So it's trying to understand where that threshold is, where you would want to, or you need a subcutaneous, so an injection which is under the skin every 2 weeks, which is what this would involve. You don't necessarily need to be in a hospital-based setting, you can do that at home, but obviously there is a threshold where we think things are bad enough that would be an appropriate course of action. It's usually when your requirement of corticosteroids is very high or very frequent, and that really is kind of the level at which these drugs are often helpful.
Can you quickly talk about, so you mentioned the drug that's in a global trial. Do you know what stage it is and what?
It's in phase 3 trial at the moment, so we're one of the sites for that at the moment. Manchester, I think, are another as well. So I think there's 2 or 3 sites open in the UK. So it's within phase 3 recruitment and it's open at the moment. So, you know, if you're interested in taking part, it's worth discussing with your local centre. And if they aren't participating, they can obviously refer you to one of the centres that are taking part.
Very good, listeners. If you want to participate and if you're eligible, then please get in touch. And you also mentioned in the article mucolytics, which is more management. But
yeah, so I mean, I think people often I wouldn't say forget, but perhaps underestimate the importance. So ABPA again is very interesting in the sense that it's characterized not always, but often by quite sticky, thick mucus, which is probably a combination of the Aspergillus itself being in there, which can be, you know, the Aspergillus when it grows forms hyphal structures, which can be quite solid, and so the mucus often is quite dense and sticky. And equally, the eosinophils, which is the drug, the cell that I mentioned before, which infiltrates into the airways, often when it gets to the airways, they then, when they're trying to deal with the fungus, they implode and sort of explode, and that releases a lot of DNA into the airways as well. And then when you have infections, you release another blood cell called a neutrophil, which is often in there doing the same thing. And so you get this sort of massive, maybe a bit of bacteria, some fungi, and then a lot of cell kind of proteins and debris in there. And that makes it very congealed and sticky. And ABPA is often characterized by that sort of burden. And so going back to basics, to airway hygiene and making sure you're clearing your airways is incredibly important, because we know that if that doesn't happen, that can drive inflammation and drive progression of the underlying disease. So in that context, we often think about using different therapies to try and break down the mucus, and that can range from something called carbocystine, which is a normal chemical that people can take orally. It's an antioxidant. To salt solutions sometimes that can be helpful to try and break down the phlegm as well. Now, I would stress again that none of these actually have been trialed in an evidence-based fashion. So there are therapies that are, for example, used in cystic fibrosis that potentially may be helpful in ABPA, and people have looked at different small studies or kind of looked anecdotally in a laboratory to show how it might be helpful. But again, those studies really haven't been done in any kind of concerted manner. But by definition, making sure your physiotherapy is as good as it can be is really, really important.
Yeah. By the way, I was given carbocystine, and it has been extremely helpful. But as you say, that's just anecdotal evidence. And I think there is one more group of therapy right now, which is immunotherapy. Can you talk a bit about that?
Yeah, I mean, that's still kind of earlier in the sort of pipeline in terms of where it is in terms of translating into clinical practice. But it's a really, really interesting area that there's a lot of research on within an allergy field, where the idea is you're trying to essentially desensitize people's immune or allergic response. And so they've done that with grass pollen, for example, very successfully. And they're doing that with other different types of allergens. But the idea is that if you remember when I was talking about your body sort of almost developing a tolerance, and we use that word in an immune setting, where instead of having an allergic response to someone, your body decides to sort of tolerate it, and not mount that kind of big immune response. And so what they do is they very carefully and measuredly introduce your body to very small quantities of the allergen, and over time see if they can shift your immune response away from developing this really over exuberant immune response to being a much more tolerant immune response. So that's really exciting for the future, but it is still obviously within the early stages.
Yeah. Are you, I think more or less a final question, are you aware of any research further down the line or in an earlier stage that would affect?
Yeah, so I mean, there's a lot of research going on, and we're doing some as well. I think one of the big things that is lacking perhaps within fungal disease generally, but equally that it applies to ABPA, is that, as I'm sure you probably know from your the people that follow you or kind of in your group, that there is a spectrum within ABPA as well. Not everyone has exactly the same type of disease, and one of the things we're learning now within medicine is that not every therapy fits everyone perfectly. And I think one of the things that we need to develop within ABPA is to really understand the different kind of groups of conditions or the groups within a condition that exist, and then really do the basic science to understand what pathways are really being active, and where the potential therapeutic targets lie. And so that's kind of work that we're doing at the moment to really try and understand that a little bit better. So, ABPA, for example, there's a huge spectrum from people that are sensitized but don't have any bronchiectasis to people that unfortunately have, for whatever reason, have the same sensitization, the same allergy, but instead of that have developed really quite aggressive bronchiectasis and scarring and unfortunate destruction of the lungs. So what is it about those two people? They have the same sensitization, the same allergy, but completely different responses in terms of what's happening. And I think the expectation that the same therapy would help both perhaps isn't necessarily right. And we should be kind of being much more precise in terms of the way we're delivering medicine. So precision medicine is kind of as it's coined, really. But the first bit, it really is to go back and understand within those different groups, what are the drivers, what are the main problems, and then it may well be that we can repurpose a lot of the therapies that are already being licensed for other conditions, and then develop a precision medicine trial. And I think that's really exciting, but I think that work still needs to be done.
Yeah, thank you so much, Dr. Shah. So to repeat, our discussion was based on a scientific article which is available to download and to view without any payment, called Review of Current and Future Therapeutics in ABPA. Dr. Shah is a co-author. I'm part of the Aspergillosis Trust, and please visit our website and our other social media. And of course, if you have any funding, please help us. Again, Dr. Shah, thank you so much for a super helpful discussion.
Thank you very much, Martin. Thank you for inviting me.
Bye.
Bye.